In about 2 weeks, we'll be in the final 2 weeks of implementing this surgery brief, timeout, and debrief, which is what the surgical safety checklist is, in all of our operating rooms for all of our patients every day. And I'm here to say that it is so simple, and it is something that we can implement, and we're here to encourage everyone to engage. And we learned some important things, and when we're successful, we'll be very appreciative for the leadership of Rick, Dr. John Hunt, and the late Michael Farnsworth, who brought to our organization information about crew resource management, which in the translation for those of us that provide clinical care every day, the crew resource management is the ability to develop relationships among the people that allow for the free flow of information and the ability to bring all of the information to the pool. But it starts with the relationships among the people. And so I'd like to tell you how we found our way to the checklist, which is really different than finding our way from the checklist. And I'll paint a little bit of a picture for you in the context of what we were trying to deal with. And just for a reference point, my job in the morning is putting people to sleep. I'm an anesthesiologist, and I put them to sleep every day in the operating room, and then on some regular occasion, I put them to sleep at night and throughout the night into the morning. And then in the afternoon, I put on an outfit like this, and I'm the operational manager for surgical services as the vice president, and responsible to the caregivers and responsible to the budget. And then I'm also a member of the board of trustees. And what's interesting about that perspective is that it takes elements from the physicians, physician leadership, the executive team of the hospital, and the board of trustees to be successful in this effort. And so this is a very appropriate group to be presenting and discussing this with, because it's our view, having been through our experience, that it will take to successfully implement with integrity the surgical safety checklist in your hospital, the leadership of physicians, your executive team, and your board of trustees. So just for context, like Dr. Gwandi described, we face 3 challenges in our operating room. One is an enormous complexity of the work, and it increases continuously. We have 100 surgeons on staff. They perform about 3,000 different operations. We do those operations 80 to 110 times a day. There are about 5 to 7 people in those operating rooms for that 80 to 110 times a day. There are 10,000 implants that we have available and about 30,000 items that are unique to surgery. They're not used anywhere else in the hospital. And we have technology everywhere, especially technology that relates to extending the senses of the doctors. And when you ask a key constituency in the operating room, which are your surgeons, what is the face of risk to them? And this is something that we learned by spending an enormous amount of time with them, one-on-one and in focus groups. They view risk, we think, as the inability to coordinate the people with the technology and the materials. And if they view risk, they view risk as not having the precise instrument at the precise moment for the precise reason. And when there's poor coordination of those things, then workarounds, distractions, harm occur. And so in the development of the checklist to be valuable for them, the checklist had to ensure that we responded to how the surgeons viewed risk, and it was in and around that equipment. And there's a lot of pushback from people saying the surgeons are excessively concerned with equipment. But the reality is, for a surgeon, that that equipment, the instrumentation, they're extensions of their hands. And the technology is an extension of their senses. And the things that they implant in people are what alleviate pain and restore function. And so those things are extremely important to their view on how they can offer care to the patient. The second major challenge that we face, that I'm certain all do in an operating room, is just an extraordinary production pressure and compelling issues about time and pace. And that's an area where we frequently hear, well, that's the surgeons exerting that production pressure, and I think there's an element of it. But for those of you who are not familiar with the environment, to be in the environment, this is the way it feels when you go into, if you're a member of the team in an operating room. It feels like, and I did this recently, so this is a good example. It feels like jumping out of an airplane in tandem with somebody and some other people jumping out at the same time, and it goes, whew. There is a pull in an operating room with time and pace that is like gravity. So that it's just like jumping out of an airplane. You know that you have to get that 12,000 feet over with and get your feet back on the ground. But the pace is set by the flow of that work and the necessity of managing time in an operating room, because time in an operating room and time during surgery directly relates to the risk of the patient, risk of complications, risk of the anesthetic, and how they're going to fare after surgery. And so, like everyone, we're compelled by time. And there's an issue with the surgical safety checklist that may pose some pushback, which is taking time for this brief and the debrief and the timeout. Is that going to slow things down? And I think the point there is to be very thoughtful about ensuring that you don't view the application of the checklist as, well, if we just slow things down, we can get this done, and then the derivative benefit can occur. Because the checklist the checklist information that's derived and the communication that occurs between people needs to allow the collaboration to excel, and that will manage the pace. And it's the only way. And so when we talk with our nurses and our technicians, and we ask them what elements of this checklist are most important to you, we would hear from them the most important thing that the checklist could do for them is allowing them to be prepared for what we knew or should have known was going to happen in that patient in that operation, and that we were prepared for the unexpected. And when you're contemplating 100 surgeons, 3,000 operations, 20,000, 30,000 items, the ability to be prepared for what we knew or should have known about that patient is essential to them, for those individuals to find value in the checklist. And for anesthesia, which is the remaining element of the triad of people that are in that operating room, there's nothing more important to the anesthesia team than understanding the time and intensity of that case. And I know it seems like we're always in a hurry as an anesthesiologist because 3 o'clock's coming up and it's time to go. And that's sort of the common characteristic of that people view in anesthesiologists. But time and intensity really determines how we see risk and harm manifest in patients. And so it's essential from our point of view that reactive postures in an operating room, reactive postures because of poorly coordinated people and things, cause time to be extended and frequently is accompanied by more intensity. And so as we looked at what was important to the people in that operating room, we came back to the checklist, because the checklist briefing, timeout and debriefing, allowed us to coordinate those people and things in an operating room. And when you coordinate the people and things in the operating room by making the free flow of information comfortable and expected, then the pace is managed and the risk reduced. And so when Dr. Gawande wrote the Checklist Manifesto, and he has created the burning platform for this approach, and he's done that for the public at the 10,000-foot level. The challenge for all of us now is bringing the Checklist Manifesto to every one of our operating rooms in the state.